Okay, so now we're going to take a look at obstructive disorders. These are very, very commonly encountered in the clinical setting. I'm sure you've seen them at some point too throughout your practice as well. But once again, things like asthma, chronic bronchitis, emphysema, or COPD, a lot of times too they overlap. So definitely we'll have patients that have both chronic bronchitis and emphysema, both physiologic or pathophysiologic states, essentially presenting with COPD. A lot of times they will have patients that present with dyspnea or wheezing, and it's very common to have dyspnea and wheezing, obviously, with all of these obstructive disorders as well. So those are very common symptoms that you will see with this. When we look at obstructive disease, so really it's about airway obstruction that's worse with expiration and basically a ventilation perfusion mismatch that occurs with it. They tend to have a decreased forced expiratory volume in 1 second, which is what we call an FEV1. So a lot of these patients have a difficult time expiring all that air. And a lot of times you've probably heard of like air trapping in these patients with COPD. So they have a difficult time expiring the amount of air that you would typically in a healthy patient or healthy lungs, essentially. And what we do a lot of times, we'll do it with like a pulmonary function test. And essentially the patient, inspires and then they do a forced expiratory phase essentially into the PFT. And they look at how much volume they can actually expire in 1 second. And it's compared to, like a healthy norm essentially. And they do put things in like such as age and the patient's weight and their sex and all that is accounted for. But it gives you a good tool to look at in terms of, diagnosis and management or monitoring of your patient. So a lot of times they'll have a reduced FEV1 because a lot of these times they'll have air trapping or the inability to expire good volume essentially with these disease states because it's obstructive. So more force or more time is required to expire a given volume of air in these patients. So, in the healthy average patient, it's not as difficult. So these patients have a harder time with it. So you will see a reduced FEV1 when you look at like a PFT in these patients. And you will get into like reading like PFTs and looking at, different lung volumes and all that in your future clinical courses. So all that comes with time as well. But really it's just to kind of give you an understanding of what you would potentially see, with these patients. They definitely have an increased work of breathing, definitely have dyspnea, wheezing. So these are very common signs and symptoms that you're going to see with obstructive pulmonary disease. The first one that we'll obviously take a look at, it's very common, is asthma. And it's, very common across the lifespan. You'll see it in kids, you'll see it in young adults, and to even the older adult. So really, asthma is a significant inflammatory disorder. It's heavily linked with allergens, especially like when you look at kids. It's very commonly linked with kids that have eczema or atopic dermatitis. You'll see it go hand in hand with allergies. There's a significant allergic component to it. So once again, when you think about that allergy and inflammation, it's all of those immune mediators and all those inflammatory reactions essentially that play a significant role in the development of asthma or asthma symptoms. So a lot of times there's precipitating factors like environmental factors, pollutants, allergens, and we really want to try to point these out or figure out what exactly exacerbates, their asthma essentially, because there's times that, we can actually do even like allergy testing and things like that if it's severe enough, obviously, to try to figure out the cause. Even things like exercise, that's a big one. Exercise-induced asthma, you'll see that a lot in younger kids. Stress, emotions, that can actually exacerbate it. But once again, it tends to run in families. You tend to see it more commonly actually when they're in younger. You'll see it more commonly in boys when they're younger, but it actually becomes more common in women as you get older. But it does have a family history component to it too. Once again, we go back to that IgE stimulated response there, that mediated response. And what happens when you get mast cell degranulation? You have all those inflammatory mediators and histamine and all that. And that's what causes that inflammatory or inflamed airway, essentially. So there's, an altered immune response. If you go ahead and read the bottom ones, where you have those chemical mediators on the left. Mucus secretion's a big one. They have bronchospasm there too, and they have decreased lung compliance. Increased lung compliance. They actually become hyperinflated because they actually trap air essentially. Impaired mucociliary function, so that basically they end up with more mucus production and they have a hard time bringing it up. So that's another reason why they have an exacerbated or exacerbations with coughs too. Alterations in O2, CO2 exchange, obviously because of the inflammation and mucus and bronchospasm that's there. These are just different mediators. Remember I mentioned it's a significant inflammatory component to the development of asthma. And it's a hyper-responsive airway with constriction there, essentially. I don't expect you to memorize all these different interleukins and, which one each does, but just get have that good understanding of the process here that, it's basically the mechanism is inflammation. So really, when you think about it, our treatment is actually guided by this as well. So a lot of times, obviously, we use albuterol in patients as well for like a short-acting mechanism or bronchodilator, but we also need to treat the inflammation. So a lot of times these patients will be on inhaled corticosteroids, to help the inflammation there, because it is obviously a significant component to it. Or medications like Singulair, that's used a lot in children as well, because remember, leukotrienes, that's a component of this. So once again, a lot of these inflammatory mediators are what we actually are targeting in terms of treatment with these patients. So that's why, once again, it's important to look at those allergens as well. How can we prevent the exacerbation of asthma, or how can we help the patient essentially with it? But if you look through the list, eosinophils, they can have interleukins, they can have histamine, leukotrienes, prostaglandins. Those are all those, inflammatory mediators that we see with that response. So what happens in the end with this inflammatory response is that there's bronchial smooth muscle spasm. So they have bronchoconstriction there. Vascular congestion because of all those inflammatory mediators. Increased vascular permeability. It's all going back to the inflammatory process if you look back at this. Edema, production of thick mucus, impaired mucociliary function, thickening of the airway walls, increased contractile response of the bronchial smooth muscle, which is basically bronchospasm. So really this airway obstruction basically increases resistance to airflow and decreases flow rates, so especially the expiratory flow. So once again, they have a hard time with that FEV. Remember when I mentioned the FEV1, that forced expiratory flow or volume is going to be diminished. They get air trapping, hyperinflation, distal to that obstruction, and they definitely have an increased work in breathing. They can have decreased perfusion of the alveoli. They can have impaired gas exchange. They tend to have hyperventilation with a severe attack because of, it's basically the response to all of it, because of the obstruction and hypoxemia, essentially. During this stage, they don't tend to have a lot of CO2 retention. However, if it gets progressive, they can start retaining CO2, and they start to get respiratory muscle dysfunction. And, it can be a severe asthma attack at this point, and they can, CO2 retention at that point and respiratory acidosis. But obviously, that's why we want to prevent all this from occurring. Patients do remain asymptomatic between attacks, and these are things that you definitely want to inquire about. How many symptom-free days do they have? How many exacerbations are they having? And their PFTs may be normal on these days. Their pulmonary function testing. But then they definitely will have triggers, and it'll be things like different seasonal allergies that they're exposed to, stress, cold air. So just different things that can trigger these asthma attacks. But they do have periods where they may be asymptomatic. They can have chest constriction. Expiratory wheezes are very common. You may hear them audibly, or you may actually hear, obviously, when you're listening to them. A cough is a big one that I always inquire about. Are they coughing more at night? And it seems to be a pretty prominent presenting symptom in children, especially too, like with exercise. That's one thing I always inquire about. Is there any coughing with exercise? They may not complain of wheezing or anything, but they may, have a dry cough with it. Tachycardia, tachypnea, use of accessory muscles, that can all definitely occur with asthma exacerbations. Status basically is when they develop a very, very severe asthma attack. And that's where, like I mentioned before, that's where they can get acidosis or they have CO2 retention. It's basically they get in such a severe state of bronchoconstriction that it's very difficult to treat at that point in time. And this is an emergent situation. So that's why we always make sure that we're educating patients on using their rescue inhaler and making sure that they know which inhaler to use, when to use it, etc., and having a plan in place in terms of treating like an exacerbation. And this is really problematic in that, the younger adult or child or adolescent when they're independent. So you've got to, make sure you're looking at that. Obviously, this is just a quick little brief a logarithm that you can look at. Once again, you got to figure out those trigger factors. I mean, we can't eliminate them completely, but we can definitely work on that because this is, it promotes that significant inflammatory response where they have mucus, airway constriction, and then swelling of the bronchial airways, essentially. And that's why they present with cough, wheezing, shortness of breath, and tightness in the chest. This is just a little bit more detailed chart, essentially kind of going through that allergen. And it's really the stuff that I kind of mentioned already about all those inflammatory mediators, mast cell degranulation, and basically underlying dysregulation there that leads to bronchospasm and all that mucus secretion and inflammation in the airways. And that's why they have airway hyperresponsiveness, essentially. So that's kind of the end result with it. In terms of ABGs, I mean, this depends on the clinical setting that you're practicing in. In the outpatient setting, we don't have access to this, and they should be in the ER or the inpatient setting if they're that severe. But really, like I said, we tend to look a lot at their expiratory flow rate, and they can do this at home and looking at it with a spirometry, and they can monitor this as well. But once again, too, like we'll look at pulmonary function tests to look at their FEV1, and really looking at those triggers as well. In terms of treatment, we do use inhaled beta agonist bronchodilators because we're targeting those beta receptors, and it basically relaxes smooth muscle. But really, you got to think about side effects with it too. It can hit those beta receptors on the heart, and they can get tachycardia. So that's why a lot of times, obviously, you have to treat it, but sometimes they tend to have tachycardia when you use bronchodilators with these patients. But once again, it's one of the mainstays of treatment. So we can use, short acting, which you want to make sure they're doing for a quick relief. And then we do target patients, depending on how severe they are, with corticosteroids. Typically, the first line is usually inhaled steroids, but sometimes during exacerbations, patients will need to be put on oral steroids as well. But really, we want to make sure that we have good control, to prevent exacerbations. Allergy testing is a big one too, because once again, you want to figure out those triggers, and sometimes they can put them on allergy injections to kind of help, those allergic symptoms as well. Following up with pulmonary function tests. The National Asthma Education and Prevention Program, there's different treatment guidelines that you can look up on there. Once again, you're not held responsible for that during this course, and you'll get to a lot of these guidelines when you move into your clinical component courses as well. I did add this on there because it kind of gives you an idea, and this is actually really a component of a guideline as well. When we look at asthma severity, we definitely look at how they're basically managing it and what kind of symptoms they're having and when are they occurring. So these are common areas that we will always assess in patients that have asthma. How often are they having symptoms? And we kind of try to branch it out into intermittent, mild, persistent, moderate, or severe. Depending on the severity that they have, this really guides our treatment and what we should be doing with the patient. If they have symptoms daily, that means we need to change something. We need to put them on a better preventative medicine. We're not doing a good job controlling them, because that's the big thing, is we want to make sure we're controlling their asthma symptoms. Do they wake up at night coughing? Is it once a week, or is it once a month, or once every other month? If it's not if it's intermittent, it's a different story. But if it's nightly, where they're waking up coughing or short of breath, then it's a red flag. How often are they using the rescue inhaler? I always ask this. How many days a week? Are they using it daily? If they do use it daily, how often are they using it? So really, this will kind of basically allow you to, look at your patient in terms of how well they're being managed or where they kind of fall into place, and it helps you guide your treatment as well. And the other thing too, like I mentioned before, is like the FEVs. We definitely look at that in terms of the forced expiratory volume in a patient. And we kind of, once again, look at it in terms of how severe it is. And really normal is anywhere from like that 80 to 120% or 100%. It's pretty much normal. So if they're greater than that, then, they're doing okay. But once they start falling below that, that's when we start needing to look at their treatment essentially. Other pulmonary disorders, and you definitely will come across this in the clinical setting, and I'm sure you already have, is COPD. Once again, you can kind of define it out into emphysema or chronic bronchitis. And I'm sure you've gone through these before, but really, it's a lot of times these patients have an underlying exposure factor there. So we always inquire about, tobacco use, any exposure to pollutions, or what do they do for a living? Because there's things that you can be exposed to that can kind of trigger this as well. But really, with chronic bronchitis, they tend to have a lot of mucus and more of a productive cough. Where emphysema, they tend to be thinner, and they tend to have a loss of elasticity there in their lungs, and it occurs more at that alveolar level. It's not uncommon, though, like I said, to have an overlap of both of them, unfortunately. But both of them lead to air trapping, just like I kind of mentioned with asthma. And they end up with exacerbations, they end up with dyspnea. They're at higher risk for infections, so we're very aggressive in terms of making sure that, number one, we're preventing infections with immunizations like pneumococcal pneumonia vaccinations, or making sure that we're on top of any pulmonary infections that the patient develops, because obviously they can have significant effects if they do get ill or pneumonia or anything like that. This is just a quick little chart. It just shows you, normal versus abnormal, and how they end up with airway remodeling and fibrosis there, just like we talked about with the heart. The vasculature there can have changes. The smooth muscle by the airways can have changes. So they tend to have like hyperinflation of the little alveoli there. That's more common with emphysema. Where chronic bronchitis, you tend to get a lot more mucus with it. This again is just another good image. When you look at like an alveolar wall, essentially this is like the area where you have gas exchange where air comes in. If you look on the left, this is looking at air coming in during inspiration. So if you have a mucus plug there, it can pass through there, and they don't really have an issue with inspiring air and getting it into the alveoli. However, what happens is that once it gets in there, those bronchial walls can collapse, and that impedes expiration, or airway. I'm sorry, the air coming out of the alveoli basically through those bronchial areas again, because it's so constricted. So it's just showing how it can go in, but they tend to trap air essentially because of this. So air trapping is very common with COPD. This is just another image I added where you look at chronic bronchitis. And I'm sure you probably remember this from undergrad as well, but these, we say pink puffers, blue boaters. Pink puffers tend to be those with emphysema, where they tend to look pink, but they're very short of breath and they tend to be very thin. Whereas COPD bronchitis, they tend to have a lot of more mucus, a productive cough with it, and sometimes they are a little bit more overweight, and they tend to have more of a cyanotic appearance to them as well. But with chronic bronchitis, they tend to have more of this mucus in their airways and a lot of swelling in there. And once again, it tends to occur up more by the bronchial area, where emphysema tends to take place more at the alveolar level, essentially, where they essentially kind of they don't get good airflow coming out of the alveoli, and it becomes trapped in there. So when we look at, chronic bronchitis and defining it, it's really, persistent. One thing to remember, number one, is that these are chronic. It's not reversible. So these are not reversible inflammatory lung diseases, where asthma is chronic, but it's reversible. They're not left with, essentially damage left there, where this is not reversible. And it's persistent, so they can have a productive cough, and this is more so with chronic bronchitis. It's greater than 3 months for the year and at least 2 consecutive years. So once again, it's kind of defining it in terms of time. Very common in smokers, so obviously inquire about that. Exposure to air pollution, any irritants that can get in the airway, essentially. And obviously they have that inflammatory response there as well. But this is what kind of triggers the mucus production, and it tends to be a lot thicker than normal. So a lot of times they have difficulty bringing it up, and this makes them more predisposed to developing infections. Because really, when you have that mucus there, it just creates an environment for bacteria to basically become kind of lodged in the area and embedded in the airway. And that's why they're predisposed as well to developing infections. Those bronchial walls are thickened. There's a lot of edema. It's persistent inflammation. And once again, they tend to have a lot of recurrent infections. And I'm sure you've seen this at some point or another, or taking care of these patients. But we want to make sure that obviously we're preventing infections in these patients as well. Some of this very similar symptoms: decreased exercise intolerance, so they're very short of breath. They may present with wheezing. A big one is where they productive cough, and they may say, they may only present with this cough. Like they, may not necessarily complain so much about difficulty breathing or wheezing. They just say, "Man, I have this hacky cough." So I always inquire, is there a history of smoking? Do they have exposure at work? Things like that, or is there smoking in the home? And really, we do, confirmation through testing and looking at their pulmonary function testing, like their FEV1. Once again, it'll be decreased with these patients. They'll have difficulty exercising. Tends to have copious amounts of sputum. Later in the disease, but even at the beginning, they tend to have a lot of mucus as well. Very, very frequent pulmonary infections. So that's a big one. We're very aggressive with treating them and preventing them. They do have a reduced forced vital capacity in FEV1, and then increased residual volume due to air trapping. So the residual volume, you always have residual volume air in your thorax or your pulmonary system, even after you expire. So like if you breathe out, there's still residual volume there, but these patients tend to have even more because they have air trapping in the lungs, essentially. So once again, it's not reversible. Smoking cessation is key. You can't reverse it, but you can help slow the process or stop progression. So it's really important to make sure that you're counseling patients on smoking cessation or exposure there. We tend to use, it's a little bit different. Like when you look at treatment of asthma, usually our gold standard treatment in terms of what we start with is a inhaled steroid. So we're using a strong anti-inflammatory strong anti-inflammatory inhaler, I should say. Where chronic bronchitis and COPD, we tend to start with bronchodilators. So we tend to start them on inhalers that will actually open them up. Expectorants can help too, control the cough, but we do tend to put them on inhalers to open them up. CPT, things like nutrition is a big thing. You see that commonly even with emphysema. They tend to be very, very thin. But good nutrition is a big thing. Once again, it supports their immune system, even fluid status and hydration. Pursed lip breathing, basically to kind of help them control their breathing patterns and to blow off CO2 as well. Antibiotics for acute exacerbations, corticosteroids for acute exacerbations. And once again, it's kind of similar to looking at like their patterns of how often they're having symptoms in terms of gauging their treatment and what we should be doing in terms of managing it better, or if we need to change something essentially. Where emphysema is, once again, they do overlap, so you will see them commonly kind of present together, but emphysema is usually more at that smaller airway where the gas exchange occurs in the alveoli. And those walls become basically fibrotic, so they don't get good elastic recoil there. So the expansion of them is not great. So when they kind of collapse and they should expand nicely. Well, once they become fibrotic, they don't do this very well. Same exact risk factors there: smoking, air pollution. There is a primary emphysema, which it's very small, and it's a 1 to 3%. Essentially, 1 to 3% is related to like an alpha-1 antitrypsin deficiency, essentially. It's deficiency of an enzyme, and it's inherited, so it's genetic. So if it runs, that's the other thing. Like you inquire about whether it runs in families, but this tends to present like atypically. Like it'll be in that younger patient that you would not expect it in, and they don't have a smoking history or exposure history. So it's a quick and easy test. Actually, it's you have to send it to like a send out laboratory, but they basically look for to see if they have the enzyme there, and it obviously you want to know if that's the underlying cause there. Treatment remains the same, but it can be caused of a primary emphysema versus secondary from smoking. I just added this. Those are just those things that you commonly see with emphysema. They tend to have CO2 retention in both of these. They tend to be dyspneic, hyperresonance because they're air trapping. So anytime it's, you have more resonant, it's because there's more air in there. Orthopnic, barrel chest is a big one that you'll see with emphysema. So barrel chest, you'll see they have an increased AP diameter. So they start to, because of air trapping, their chest, the shape of it essentially changes, and their AP diameter becomes greater than what is normal in a healthy patient with, normal lung function. Once again, they tend to be very thin because a lot of these patients unfortunately have a difficult time even eating because they have such, lung dysfunction that it's even difficult to keep up with that. But this is just an image on the right too, showing what the alveoli kind of look like in terms of damage there. So there's a breakdown of elastin. It's usually initiated by, irritants such as cigarette smoke. There's airway inflammation, and then there's obviously that infiltration of those inflammatory components like neutrophils, macrophages, lymphocytes, and all those inflammatory mediators there. So really like I mentioned before, it reduces that elastic recoil of the smaller airways there, and they get air trapping with it. And they end up with hyperinflation of the alveoli. And they can get like basically larger areas of air, which they call bullae, or basically they can have other areas where they're adjacent to the pleural, they call blebs, that can develop too. But really their lungs become ineffective at gas exchange, and those areas are definitely ineffective at gas exchange as well. There's an increase in residual volume in the alveoli and diminished caliber of bronchioles, so just from the airway remodeling that they have there. So once again, they have airway trapping, hyperexpansion of the chest, increased work of breathing. They end up with hypercapnia or elevated CO2 levels, and they have persistent inflammation. They tend to have weight loss, weakness. I already kind of went through all this with infection and all that as well. It's very similar to those risk factors, and what we are worried about is similar across the board in terms of emphysema and COPD. But really, it progresses and it can become dyspneic even at rest, unfortunately. So a lot of times, too, these patients tend to be thin. You may often see them kind of leaning forward with their arms kind of in front of them to basically open up their chest to increase lung capacity there. And, sometimes we can do things like pursed lip breathing with them. This is an example. Like you can see how he's kind of got, they call it like a tripod position where they kind of sit forward. Or you can even see a little bit of that kyphotic in his back, or even like an increased AP diameter there. It's not that significant on the left, but if you look on the chest x-ray on the right, you can definitely see how that AP diameter is, widened essentially. And there's more of that barrel chest there, which is very common with emphysema. This is just a quick chart that kind of gives you a rundown of the patho there. Same things I've mentioned, air pollution, tobacco is a big one. Obviously, you have to counsel about that. And really, it looks at all those different things like your inflammatory response, bronchial inflammation, irritation. And the left side looks at chronic bronchitis, and the right side looks at emphysema. But like I said, a lot of times, unfortunately, these coexist, and it's basically a dual diagnosis under COPD, essentially. But really, in the end, it's air trapping, obstruction, frequent exacerbations. Those are the big things. Like, unfortunately, these patients end up in the hospital a lot with exacerbations. So we want to make sure we're managing them well and preventing that, essentially. So making sure that we're on top of their medications and immunizations and treating infections aggressively in these patients. So they'll have a decrease in FEV1 as well. They do have an increased residual volume and total lung capacity, so they're just retaining air there. When you look at a chest x-ray of these patients, sometimes you'll see the diaphragm is actually flattened out. When you look at, a healthy patient, it should have like a nice curve there, almost like a upside down U kind of, when you're looking at the bottom of the lung tissue where the diaphragm basically is. These patients tend to have more of a flattened diaphragm in an x-ray because their lungs are over distended with air because they're retaining air. So sometimes you'll see that that edge kind of blunted out essentially with a chest x-ray in these patients. Mainstay of treatment is bronchodilators, corticosteroids for exacerbations. We do use anticholinergics and beta agonists, which are bronchodilators. But they really look at improving like the quality of life in these patients, of looking at like with anticholinergics and reducing the mortality rate with these patients. So there's a multitude of different agents that we use, but usually they start with like a bronchodilator at the beginning stages. Usually it's a long-acting one to kind of help throughout the day as well. But once again, we're looking at the patient in terms of how many exacerbations are they having, what symptoms are they have on a daily basis in terms of how to approach management for these patients. When you get a chance, you don't have to do this now because you will get into this in your future clinical rotations or your future courses. When you start to look at, how do we manage it or what symptoms will we look at in terms of diagnosis, the GOLD initiative for chronic obstructive lung disease is a great resource and a great tool. And this is kind of what develops those, and I have it on the next slide, a quick little image of it, but it looks at those symptoms and looking at the FEV1. But if you go to their website, there's actually great resources on there about looking at PFTs, and you'll definitely get into like reading PFTs and all that in your future courses. But if you're interested, you can go ahead and take a look at it. Just go to their website. There's a lot of great resources on there for COPD. So GOLD staging, like I mentioned, like they'll come up with these guidelines in terms of how severe they are, from mild to moderate to severe, obviously, and so forth. And really, and why is it important? Because it's really important to look at in terms of, are they being managed well, and do we need to change their therapy? It kind of helps us gauge what to do with the patient, essentially. So you don't need to know this now, but once again, when you look at like the FEV, like it'll help you, it'll tell you like how severe their COPD is, essentially, when you're doing a PFT. I added this other image because you'll commonly hear this, and I'm sure you've heard it before, but a lot of patients don't really know, or they've never been educated on it, but they actually say they have asthma. And really, it's most likely not asthma if they're a smoker. It's usually COPD. But a lot of times they think, oh, I have asthma, and it's because they're on an inhaler and they don't really put it together. But really, there's a major difference, obviously. Asthma has that allergic component to it, an inflammatory process that's, mediated by allergens, where COPD is really more related to their history of smoking and social factors there. And really, asthma is reversible. Remember, I mentioned that will be reversible, so they don't have damage to their lungs that's long-lasting there. Where COPD there's not reversible, and it's very progressive, and the outcomes, unfortunately, are poor, with COPD, unless we start managing it and, make sure that we reduce smoking and all that. Okay, so the next one we're going to go ahead and put on a separate lecture that discusses infections and pneumonia and so forth. If you have questions on this, please let me know. Thank you.